And I don't want any of the providers, and we've said this multiple times, is going down to the EMT. Don't be afraid of this thing. This is definitely a tool that's going to help you, and you have a very exquisitely low risk of harm. And for the paramedics that are starting IVs, you probably have a higher risk of causing harm with an IV than you do with this mask. Back to CPAP.
Back to CPAP again.
Sidetrack.
Now, we promised ourselves we would digress, but we would actually come back. And we would finish onto protocol. And I know there's a few things that I intentionally printed off of here. I think everybody is generally of the mindset of, there's two big things we use it for in protocol: CHF, pulmonary edema, and respiratory distress.
What else can we use it for?
There's a couple things buried in protocol that don't get talked about, but let's hit the low-hanging fruit first, and then make sure we hit these other couple of things that I don't know that we've stressed all that well. Some trauma and some other medical things, but
So I'll start that off.
Yeah.
Indications for positive pressure ventilation are, obviously you said COPD, of course asthma. We got pneumonia and bronchiolitis, especially in our pediatric patients. And then also do not intubate orders. So
DNR right on my list too. Yeah, absolutely.
they call you, they don't want to be intubated, but they want some help. CPAP's perfect.
They're air starved.
Yep.
They're hypoxic, but they're a DNR, right?
Yep.
And I would hope everybody's comfortable with putting them on at least non-rebreather. But I think that mindset is like, oh, I'm putting them on a ventilator. It's still not a ventilator.
DNR does not mean do not treat.
It's a do not treat, exactly.
It's do not resuscitate.
Correct.
And, supplying constant pressure it's not a ventilator. There's not in and out, right? It's just strictly in, thus doesn't meet any criterion for ventilation.
Now, I will give a caveat that if we're talking about the hospital BiPAPs, I have a backup rate that I can do, and you could consider it.
Gray, yeah.
It is tricky and gray, but it's not what we're going to talk about in the pre-hospital setting.
Correct, yeah. Certainly no backup rate on here.
There's not a backup rate on all the
The
places.
backup rate on these devices is 0.
Yes.
And the clear-cut way, too, is the state of Ohio has a whole PowerPoint that talks all about DNR and talks about how you're able to utilize CPAP. So, because that's a question we get a lot. Can I use this? Yeah. Right? You bring up a valid point, and a lot of people think it's I can't treat them. Right? No, so I'll just put them on that non-rebreather when they benefit greatly from that. You're not doing CPR on them.
And if that's what the patient wants, that's what the patient wants.
Mm-hmm. Yeah. Oh.
So other indications, you kind of hedged on or kind of stopped on DNR there.
My only last one I have that is probably not we have great data for, but there's meta-analysis to suggest that even in blunt chest trauma.
It's in the protocol. Yeah. That's what I was alluding to earlier. Yep.
So for those patients that non-rebreather's not cutting it and you want to give a little bit of positive pressure, CPAP is appropriate. But just be mindful of if there is any injury to that lung tissue that you're going to have a higher risk and a quicker deterioration with a tension pneumothorax.
That was
so we're not using sandbags anymore for flail chest?
Correct.
No duct tape.
No duct tape.
No duct tape, and so you kind of did an end run around the low hanging fruit. You went for the traumatic breathing protocol, but that is what I know a lot of people just kind of gloss over, and I don't know that we've done a good job of hammering that in our CE. Is absolutely as Yeah,
but why am I not taking deep breaths if I have a flail chest segment? I mean, ribs are broke. I can't take the breath, so what am I doing? I'm going to help them
splint it up.
Splint it up with ventilatory support. Absolutely. And CPAP is perfect for that.
And your point's well taken there. Is if you have enough force to the chest to break multiple ribs, to have a flail segment, you have to be super cautious. About are they bleeding in their chest? Do they have a pneumothorax, simple or tension developing? You have to be very judicious with turning that up, and you have to be patient focused.
And it's constant reassessment.
And it's constant reassessment, and it's using all your tools, your pulse oximetry, your capnography, and eyes on that patient at all times. That's not the one that you go, oh, now's the time to do my charting.
Yeah. I'll say constant reassessment is going to be listening to their lung fields multiple times during transport while they're on positive pressure.
Absolutely.
Because if I had great lung sounds and now I've lost lung sounds on the side, I'm going to assume that there's a pneumothorax developing.
And we need to, as a profession, need to get better at lung sounds. That's one thing that I feel that, for some reason, there's apps out there now. There's YouTube videos. You can put your stethoscope on the speaker and hear these lung sounds that we're talking about. But it's just oscillation is being underutilized so much.
There's a company out there that actually has a set of stethoscopes where a trainer can pick what sounds you hear as you press to help do that training too. I mean, it's something we did in med school.
So cool, yeah.
But
That's pretty cool.
you can, whether it's a wheeze, whether you hear no sounds, whether you hear crackles, whether you hear rails, whatever it is, you can recreate that so you
Let's
know.
hear it. Yeah, let's hear it.
Absolutely underutilized. I'm bad at it myself. So I've, always carry mine in my right pocket, and I've
Is it there right now?
Made my, what's it?
Is it there right now?
It is, no, it is not. The, when I have my blues on, it's in that pocket, and it's my routine is, hey, I'm Scott, I'm a paramedic. I do, basically two things because I know I'm going to forget to do them. I touch my patient, I take their radial pulses, and put my ears in, and I'm listening to them. Hey, let me just listen to your lungs.
Well, without digressing too far, with just feeling your radial pulse, I can diagnose a lot in about 3 seconds.
I can get a lot done, but I have to front load it because I know I'll forget it if I put it off. Right?
Yeah, but if I go up and I go, hi, I'm John, I'm a paramedic. What's your name? And you say Scott. I'm like, everything's intact. Everything's likely okay.
Is he
I've got a crowded pulse.
Is he fast? Is he slow?
ABCs,
but
taken care of.
To his point, if I don't immediately then just go to,
you probably won't
get I'll forget. I won't get back.
And I do
the only other
thing
time is when we intubate. Generally, okay. But capnography has really helped us out in this way. And don't get me wrong, we are definitely doing oscillations when we intubate, but we need to be utilizing those more. And I mean, simple things like you said, the app or getting. That's a great tool to use. Let me hear what it is I'm listening for. If it's wheeze, where is it? Upper or lower? Lower. We can make.
Or am I hearing wheezes upper and nothing lower? That's a finding.
That could be a finding.
Does that mean that they're aerating their upper lungs and not their lower lungs, and I need to give some aerosols to that? I'll even go as far to say is that likely the stethoscope you guys have in your squads is not adequate enough. If you want a real stethoscope, not an ad, Littman.
Yeah.
Littman, I have a cardiology 5. I recommend the cardiology.
It's a classic too.
Yeah.
That's it. As long as it's a Littman, much better
But
than.
no, you're right. How many squads do you see with a dual tube that they're smacking each other? You can hear it.
Yeah.
And no, you're right. Or it's the cheapest stethoscope because what are we doing with them? We're throwing them around and we're destroying diaphragms.
They're destroyed.
But no, you're right. We need a good stethoscope. I think that should be as intimate to a paramedic as a pen, a wristwatch. They should have their own stethoscope.
I agree.
Get your own. Get a good one that works for you.
And I've done this with nurses in the past. Like I see crappy nurse ones. I go, here, listen with yours, listen with mine. They're like, oh my God, you can hear things.
Right.
Like, yes.
Yeah.
But now,
and I'm going to do that with paramedics. I'm like, here, you're going to listen with your stethoscope, listen with mine. What do you hear?
and why wouldn't you want the better tools? I mean, if we're in the back of an ambulance doing 60 miles an hour, what am I hearing? Road noise with that cheap stethoscope? Get the tools for the trade. Get the right stethoscope. You're right.
Yeah, there needs to be a little onus on us to like, hey, I need the right. Furthermore, I like all you guys, but I don't want to put stuff in.
I don't want your earwax on my earwax.
I don't. Right? I've got that bent. It just settles into my gourd. Exactly. I get the same thing every time.
Yeah, they're pointed.
I took the tips off. It just. I'm always bleeding out of both ears at the end of each call. So, and I have a couple other indications here. Kind of not protocol stuff. It's really just kind of some obscure stuff that we may come across in stuff like an ARDS patient, high altitude pulmonary edema. Hey, we're in Northeast Ohio. That's probably not, but if we wind up out of state, and you're heading out west, so
I am. I'm climbing Mount Bora next month,
and I hope you take some time to acclimate so you're not drowning. Drugs and toxins can cause non-cardiac pulmonary edema. Drowning. How about
It happens. Somebody just drowned in Lake Erie on a dive the other day, a scuba diver.
Drowning, near drowning, if that actually exists. And then for our fire service guys, how about smoke, gases, smoke inhalation, right? And then
And that's a great point. One thing that we don't talk about enough is CO poisoning and CPAP.
So that is the other we're apparently not going to talk about the low-hanging stuff. We're just going to go
let's hit
directly into. We're going to go directly into.
This is completely underutilized in that aspect.
So what is the treatment for CO poisoning?
Right now,
Well, what's the gold standard?
Gold
get them out
standard
of the
is
environment.
and hyperbaric oxygen.
Hyperbaric.
Hyperbaric.
And we don't have. There's nothing around here that we can do hyperbaric with. So our next best bet is going to be 100% FiO2 CPAP.
We touched on this a minute ago.
Yeah.
We got to double down on this because he said the very important piece here, which is 100% FiO2, and these Venturi devices that plug in, they're in training room air. So this can't, in its natural or in its supplied configuration, this cannot give us 100% FiO2, and that's where this thing shines, right? I mean,
Yes.
and of all of my praise, that's it. The mask causes me trouble, right? But
Easily correctable, though.
this is easily correctable, right?
Yeah.
So I hope every single provider level is already putting their CO2 sampling cannula with an oxygen
Should be. Should be.
on anyway,
Correct.
right? That better be the gold standard at the time of this recording, because if not, we have failed miserably in getting that message out.
Epi 1 to 10 or 1 to 1?
All IV, right? You just continue to turn up. Now you need a second oxygen source, right? And that is, again, that is kind of some pre-planning here and things that have to be thought about. Do you have a second? Hopefully you have two ports in your ambulance, right? So you can plug one directly in, as we've talked about, not on the flow meter, and then plug your
I
oxygen.
mean, you're always going to have a
or
portable.
oxygen source,
Yep.
right? And then what do you turn it up to? I have my oversimplistic answer. It's just turn it up till it stops, right? And,
Turn it up till it hisses at you.
it just turn it till it stops. We've been conditioned that no more than 6 liters through a nasal cannula, right?
These ranges, we have to stick to
it's
it.
gonna-
You can't
Turbulent.
vary.
Their head's going to
Right,
explode.
turbulent
There's
air.
going to be, brain matter dripping from the, from the top of the ambulance, and that's absolutely not the case. And when I do an oxygenation lecture for the class, I do it with 25 liters in my nose. It's terribly uncomfortable. My nose is very cold, right? But clearly
It
it's
works.
not harmful,
It
right?
works.
It's not harmful. So yeah, I mean, turn that up until you get sats you like, or
Augments it. Yeah.
yeah, you're augmenting that. We know that that's I said downfall. It's kind of a pitfall in that style of device, not even that brand. Augment. You said it's easily correctable.
Yeah, easily.
Dial it up, and don't be afraid of the higher flow. I mean, I hope after COVID, nobody is scared of high flow, anything up the nose, because I mean, it's what are we? Basically, every single patient
Everything. Yeah.
the knobs.
Everything we
Yes.
have.
Yeah. Put that nasal cannula on at 15, and then pile a non-rebreather on top of that at 15, and it's or 20 or 25. Right? Turn till it stops. But assuming they need it, right? That's assuming they need it.
So yeah, CO poisonings.
Yeah, back to that, but 100% FiO2. So
Yeah.
So your CO poison patient, I just turned that till it stopped, right? For the benefit of your patient.
But this is a great way to wash out the CO and push it off there and get oxygen where it needs to go again.
So another thing, I guess, to talk about and with protocol is what do you do? So one of our contraindications we were talking about, and I haven't really gone through an exhaustive list yet, is mental status, right? So what do we do with the patient that's hypercarbic, kind of on that verge
Sleepy.
of, yeah,
Yeah.
not just sleepy, almost out.
Almost out. Yep.
External rub just to get them to kind of talk to you. What do you do in that case?
Yeah, CO2 narcosis.
Yeah. What can you do? Give them BVM, really. I mean,
You can.
push oxygen in if you need to.
A trial of CPAP.
Trial of CPAP.
Yeah,
I would go for a trial of
yeah,
CPAP.
So here's one of the
Just
beauties
not
of
putting on the
CPAP.
headgear, you know?
Yeah.
Just,
Yeah,
that
you might
could
just be
be
holding
something
it on.
where you're holding
Absolutely.
it versus
If I strap
truly
this to my
committed to it
patient's
100%.
face and I put my CPAP on and they don't tolerate it, I have now created a mask that I can be hands-free with my BVM.
Yeah, the transition is easy.
So the transition's super easy. So yeah, why not trial it? Why not start with this? And if you digress, we can always go back to what we know best. And I just feel it's better anyways. The strap will hold it right where you need it.
So imagine the patient that's kind of on the verge, and I'll be honest, most of our respiratory distress cases you don't want to intubate. And you don't intubate those cases because whatever the body's doing naturally, we can't do with an ET tube and a BVM or even an ET tube and a ventilator. I can't reproduce 38 breaths a minute on a patient that's paralyzed. I just can't. If that's what their body's requiring, I can't replicate that artificially. If the patient's somnolent enough, if they're somnolent, breathing on their own, they're not vomiting everywhere, I think it's worth a trial of CPAP, because if they take a few breaths and they're maintaining their numbers look good, and then they start to wake up a little bit because they're starting to blow off that CO2, you saved that intubation. You're on the appropriate treatment. Now it's just treat with diesel to get to the ER.
LSDs, sirens, diesel.
Absolutely. How about skilled, educated, professional provider in the back of the ambulance taking care of the patient? And get them to the appropriate facility in a safe manner. That aside.
trigger word.
Yeah.
Well, actually, you and I were talking the other day. I don't like running lights and sirens from a scene because that tells whoever I'm around that I can't control my environment.
Yeah, right,
I'm a paramedic. If I'm running lights and sirens from where I am to where I'm going, it better be in the case of a situation I can't handle, a stroke,
it's time
a
sensitive
trauma
stuff,
I can't
right?
get
Stroke,
stopped
STEMIs,
bleeding,
traumas,
STEMI.
yeah.
So otherwise, I take that as an insult if I have to turn the lights on. So
Correct. Yeah.
Well, from an operations standpoint, what does lights and sirens get you for transport?
not a lot,
Exactly.
not a lot. You're not saving a lot of time anymore.
What's your increased risk of having a motor
lot.
vehicle accident?
Exponentially higher, yes.
So I think that's a mindset that you're starting to see turn now. That we're going away from that, which is a good thing because that's telling people that I'm doing my job. If I can handle it, I don't need to rush there.
Absolutely. So he brought, and you brought up this hypercarbic patient, right?
Correct.
This sleepy or almost out hypercarbic patient. But as far as contraindications, often it's, CPAP contraindication is noted as altered mental status.
It is.
And I think we need to tease that out a little bit because that may be over extrapolated from unconscious unresponsive because if the patient, let's go from hypercarbia, let's go to this patient, CO2 is okay, but they're hypoxic as all get up, right?
Yep.
And so we got the super hypoxic patient. Well, what's the first thing? What's the first thing that's going to cause change in mental status? It's hypoxia. It's hypoxia, right?
Yeah.
So differentiate. I think it's worth the exercise. They're like, what's causation here, right? And if everything's pointing to hypoxia, and the patient is controlling their airway, right? And like we were talking off air, there's not saliva pouring out, and they're not snoring.
You chewed your pork chop.
Yeah. The entirety of the pork chop is not in your upper airway.
Am I red? Am I turning red?
Slightly. Then in that case, you have the fix, and you will watch the mental status.
But
Change.
again,
Better.
if we have somebody who is unable to maintain their airway, what's the first thing we go to? A BVM, right? Until we've gotten our advanced airway equipment ready or whatever it might be. If you're a basic squad, unless they're pulseless and apneic, you're sticking with the BVM anyways. So it's already there. Now all I do is I tilt the head back a little bit and squeeze.
Well, so I think that we have oversimplified the altered mental status as a contraindication to CPAP. What we're actually trying to say is that if the patient's altered to the point where if they start to vomit, then they're going to have a compromised airway. Also understanding that by doing positive pressure ventilation, you have an increased risk of putting air into the stomach, and then you have now a risk of that aspiration. So in these patients that are kind of borderline, CPAP, head of bed at 30 degrees, let them go. If they're able to ventilate on themselves, I think that's okay to let them do that.
You're absolutely right. And
Somebody-
why are we inflating the belly
and if
over
someone-
vigorous bagging? And
Well, that's what you're doing with BVM too.
Yeah.
And you're probably doing it more
Probably doing it more with the BVM.
with BVM because you're actually going over the sphincter.
Right.
The upper
pressure.
esophageal sphincter. Yeah.
Yep. So once you go, and that's why we have our pressures of what they do. Classically, the teaching is if you go over 20, you're going to open that sphincter and cause air to go into the stomach. CPAP, that's why we limit it to a certain pressure because we don't want to force air into the belly. It's going to happen. It's not like you're pregnant. It's yes or no. There's a continuance here.
Somebody out there just extrapolated from what you said that you should give Zofran to every single patient to
No.
prevent vomiting.
Well,
I want to make
While
sure
using CPAP. yeah.
while using CPAP, but I want to make sure that
Well, no,
clearly was not.
No, that's not what I'm saying.
I think a lot of people do get confused where they're altered. Well, what do you think that carbon monoxide poisoning is going to be?
Yeah.
They're going to be hypoxic, right? So maybe they see panicky, not following commands, and like, oh, they're altered. I can't use it. It's like, well, no, they're altered because they're hypoxic.
Yeah.
If you put them on the CPAP, you can improve it, right? But back to the point of, they're unresponsive. It's not a ventilator once
Correct.
again. So I think that's maybe an easier way to try to blur that line of what's the cause, right? What good can we do with it? Know when to change gears, and that's going to be good clinical decision making on the provider's part, whether it's an EMT or it's a paramedic. And I think it's simple to figure out, in all honesty, if you're doing a good assessment, figuring out what's wrong, monitoring, if I did an intervention, how is my intervention working, right? So there's always, we assess and then we're reassessing. So if I gave that nitro, did it work?
Yeah.
Do I make that decision to give the next one? So I think it's about reassessment as well, evaluating what we've done, seeing do I have improvement or do I not?
as with most everything we do, the contraindications pretty much speak for themselves, but I think even more so for CPAP. If you look at what the contraindications actually are, it just kind of fits in. It makes sense.
Yeah.
I mean, and vomiting, that is a
that's understandable.
contraindication.
That's the big concern about ultramental status is that if they do vomit, they won't be able to then get the mask off to get the vomitus out of the seal we've created. But if they can't necessarily do it themselves and they're on that borderline and you're like, I know what this is, I can fix this with CPAP, and I can watch them and I'm watching them and they do vomit, then
Yeah.
I can be the intervention.
Mm-hmm.
Yeah.
And then at that point, you're going to reassess anyways. You're going to suction the airway, and then you're going to probably
Absolutely.
consider intubation because we've now failed CPAP, right? And we're going to go on to the next step.
And that's kind of the beauty of EMS is I can guarantee at least one-on-one patient care ratio for the entirety. At least, right?
Yes.
Often more.
At least.
Often more. At least
We hope.
one-on-one, right? I'm not being called into the STEMI in the door next, at the room next door. I'm not being called to the stroke down here.
No, you have given you have
You
my
are
attention.
one on- yeah,
Until I
yeah,
get rid
yeah.
of you, you are mine. Yeah.
Absolutely.
Yeah,
And,
so I'm not being called away to somebody else unless it's a mass cas, and then we're talking about something completely different.
I think
But
we should honor that. Yeah, we're talking about an abstract situation. Most situations, and I think we should honor that and make the best of that time, because that's what we're here for.
And I don't want any of the providers, and we've said this multiple times, is going down to the EMT. Don't be afraid of this thing. This is definitely a tool that's going to help you, and you have a very exquisitely low risk of harm. And for the paramedics that are starting IVs, you probably have a higher risk of causing harm with an IV than you do with this
Then
mask.